motor exam, what we'll do is this. There's three portions of the motor exam. Folks kind of usually jump into the very last thing, but you want to emphasize tone, bulk, and then strength. You do strength last. Everybody remembers strength because that's the easiest thing to remember. So for tone, basically what you want to do is to have you do just relaxed movements. The patient's not helping me. I'm moving the patient around in ways that he is not anticipating and in a kind of a random way, and I'm feeling the resistance of those movements of the joints, okay? Reduced tone, I think, is actually fairly hard to kind of pick up on exam. Sometimes you can feel it if you kind of know the context of the patient. The most classic increased tone is, say, the clasp knife type of thing. You know how you open up a pocket knife, it has the greatest resistance at the beginning, and it kind of opens up, and so that's kind of what you get, kind of, when you make a movement, it's harder at the beginning, and then once you get going, it kind of more easily happens. So when you have your demonstrator here on Friday, that's, some of you may want to have that type of situation, all right? And then for the lower extremity, what I usually do is just to go ahead and just kind of grab right behind the knee. When I examine patients, I usually kind of do things in a streamlined fashion, so I don't have them sitting up, lying down, sitting up, lying down. But for y'all here, I'm gonna be shifting the position a lot. So just to kind of hone in on, we're talking about tone right now. So having the person lying down for lower extremity, you can kind of see his heel remains on the bed, right? So if his tone was increased, just kind of give me a little resistance there. See how his leg would kind of kick up and off the bed there and things, okay? So that would be kind of the increased tone that you would see in leg. All right, and then the next is atrophy or loss of bulk. You can look at individuals, we all have different bulk, and there's certainly a range of being normal, but certainly when something is out of proportion, say for instance, say the intrinsic muscles of the hand, say right here between the thumb and the index finger, the calf muscles, the quadriceps, that type of a thing, you can demonstrate, or patients can show you atrophy. For your patient to be examined on Friday, I'd suggest maybe that they, kind of wear some gym clothes, that type of a thing, so you kind of point that out during your presentations and things, okay? And then for strength, what I do is for the upper extremity, what I'll test first is for the shoulder abduction, or mainly deltoid. So go ahead and have you kind of hold the steering wheel for me, and then kind of push your elbows out for me. Out, there you go. So that's deltoid. Now for shoulder external rotators, or kind of the strap or the rotator cuff muscles, mainly spinatus, go ahead and kind of pull the steering wheel. Pull the steering wheel apart for me. Push, keep your elbows in. So that's the external rotators. And then test for elbow flexion or biceps. Arms up, thumbs in. I usually test both sides at the same time. When push me down is triceps elbow extension. Finger abduction, so usually kind of test kind of right there. Palms up for thumb abduction, push up right there for me. Again, usually I'm kind of testing both sides, because usually folks will say have good side and bad side, and nothing happens over here, then right, that one goes, that one's weak. You kind of get that internal control, so to speak, okay? And then for the lower extremity, I'll test a hip flexor, so go ahead and have you push up right there for me. All right, and then knee extender, so the quadriceps, push up right there. Okay. And then I'll test various dorsiflexor actions here. So let me have you kind of cock your feet up like that. First I'll test the hallux, or the big toe, all the little toes, and then the whole foot. Okay. And And then I'll test for foot inverters, so I have you kind of roll your feet in towards each other, and then push in, and push in. All right, so that's the motor. Reflexes here. All right, so you want the reflexes in a slightly extended position. So for biceps, you guys can see that movement, right? So, you want to give some force. Usually, kind of the same force each time. It's not, you kind of want to let the reflex hammer slide between your index finger and your thumb. All right, and then for triceps, usually kind of extend it out there. There we go. Okay. And then brachioradialis, again, this is usually with the kind of see its wrist movement there. All right, usually the broad portion of the hammer for both the triceps and the brachioradialis. Lower extremity, kneecap is kind of on the inferior patellar tendon. He goes real good. And then for the ankle jerk, usually just kind of push the foot up just a little bit there. And you can kind of see it pushing down, right? Okay. So obviously reflexes can be increased, can be decreased. It's not really something you can fake, okay? Which is why, again, reflexes are so important for the neurologic exam. Folks can't really consciously inhibit those things. So, okay. Now, the last reflex is Babinski. Then you have to go ahead and lie down. Babinski really should be done with the legs extended, the patient supine. And this is a little bit uncomfortable, a little irritating. You kind of make a reverse question mark, starting laterally and going medially. And really what you want to pay attention to is the big toe. Kind of demonstrate over here, since this big toe is closer to you as I do this, and it should go down. He doesn't, he's kind of more mute than anything, and that's okay. Usually the toes would kind of curl down. Okay. We have you, relax.
So how much pressure are you applying?
It's supposed to be irritating. Okay, was it irritating?
Yes, sir.
Okay, so what I want you to do is, go ahead and close your eyes. Go ahead and subtract 7 from 100.
790, 100, I'm sorry, 93.
All right. Just trying to distract him a little bit, but see if some distraction would get his mind off of that, see if Babinski would be truly demonstrating. When it's positive, the toe goes up. The toes flare and the big toe goes up. And then one more thing I wanted me to demonstrate was gait exams. You stand up, you just have the patient walk normally, just kind of walk down, and you look at the arm swing, the breadth of his steps there, that type of a thing. And then next is really 10 gait to have you just kind of walk tightrope. So obviously you can relax. If someone is spastic or has decreased strength, you're not going to be able to walk very well. I'll be popping back and forth if you have any questions about, well, gee, how do we demonstrate this, or kind of go from there. And that's one. Now, sensory exam. There's 5 main modalities that I'll test. I'll test light touch in the areas that I normally test. Certainly for your case, if your case says, well, he has loss of pinprick in this area, then kind of map that out. I forgot to do that, actually, I'm thinking out loud. Maybe I'll demonstrate for you guys how I would map it out in just a second. So I would test for light touch, kind of, say, in the shoulder area. So for a C5 area here, and then so the lateral lateral forearm would be C6, middle finger would be C7, kind of C8, kind of medial aspect of the wrist and forearm, and T1 kind of around the elbow. Okay, C5 through T1, and then for the lower extremity, I'll start low and work high. So S1 is kind of around the heel. L5 is on the dorsum of the foot. L4 is the medial aspect of the leg, and L3 would be right on top of the thigh. Okay. if your case has different levels, then go to that different level. If he has some type of, say, a T4 spinal cord level, we are talking about the spinal cord, I like, on the back of the patient kind of say, okay, that's normal, right? Yeah, that's normal. Tell me when it changes, and then kind of walk down the back. Okay, changes right there. And then so you kind of get a feel for where on the trunk where that meets, and you have your landmarks, T10 umbilicus, T4 nipples, that type of thing. You can kind of gauge things from there. You can also certainly compare side to side. Again, one thing that I didn't do across the hall, maybe you should go back, is to say, okay, folks will tell you, hey doc, my hand is numb. Okay, so you establish, say, okay, that's numb. Yeah, that's numb. Okay, so you can say, well, tell me when it starts to feel normal again. So I'll just walk and say, okay, right there, is where it changes, and so you can kind of mentally mark that. So again, kind of pertinent to your cases and for your demonstrator, oh, there's where it turns normal for you. Okay, does that kind of make sense? Okay. So the modalities that I test: light touch, temperature. Your tuning fork's a nice thing. This is truly cold. Okay. So in your various areas, light touch, temperature. Since I've got the tuning fork in my hand, need to be models of efficiency in the clinics there. So go ahead and test for vibration here. You feel that buzzing?
I do.
Okay, tell me when it goes away. And when it goes away, you don't have to hold it. You can just kind of,
it's gone.
It's gone. Okay. So if he doesn't feel it at the toe, I go up to the ankle, or I go up to the tibial plateau or kneecap, that type of a thing. Obviously, the more proximal I go, the greater the deficit would be. Okay. All right. And so since I'm down here, so light touch, temperature, vibration, and then proprioception. It's actually how you kind of shift around 90 degrees over there. This is just so you guys can see what we're doing. Okay, so I'll grab the sides of the big toe and then kind of demonstrate to the patient, okay, I'm going to move it up, we're going to move it down. Okay, close your eyes. You tell me which direction.
Up, down, down, down.
Okay, so again, the order, I'm kind of making up the order from patient to patient. I know what I'm doing. He doesn't know what I'm doing, but I kind of get the degree over time of what's normal versus abnormal. Obviously, if I yanked it way down here, and he said, I don't know what you're doing, that's abnormal. Or, gee, doc, I don't feel anything. Okay, then I'm going to move the whole foot. That type of a thing. Okay? And then, if you guys have a safety pin at home, you guys can maybe bring that in. The best thing I can do for pinprick or painful touch is just to kind of snap the Q-tip in half, and it's a bit sharp, yeah.
Yep.
I mean, it's not terrible.
Not bad.
But yeah, I like to use safety pins, and because that really gives me something really sharp, and you can kind of say, okay, this is different than that type of thing. Okay. So light touch, temperature, vibration, proprioception, and pinprick. Okay, those are the 5 sensory modalities. Since I'm still on sensation, but again, I don't do it in this order. I kind of do the patient sitting down, lying down, and standing up, so they're not exhausted by the end of the exam. Just for demonstration purposes, let me have you stand up, and we'll test. I understand Dr. Mears went over Romberg testing with you, and so Romberg testing. I still have a lot of 4th-year students who forget this, but basically with Romberg testing, I'm testing dorsal columns. I'm not testing the cerebellum. For us to stand upright, we need 2 systems. We've got 3 systems to help keep us upright. The vestibular system, the proprioceptive system, and our visual system. Okay? So, in Romberg testing, I'm assuming that the vestibular system is intact. So you really can't test Romberg in someone who's dizzy, who may have an inner ear infection or something like that. That's not fair. Okay? So to test Romberg, go ahead and put your heels and your toes all the way together. All right? So vestibular system's intact. Close your eyes. Now, all he's got to keep him upright is the proprioceptive system, because I'm assuming vestibular, and he's doing fine, right? Okay, now, if someone doesn't have an intact proprioceptive system, when they close their eyes, they've only got one system keeping them upright, so they can't do it. Now, in someone who's trying to feign something, they're going to kind of sway and rock around and things like that. But if you think about it, that's going to take more coordination and input from the posterior columns and the cerebellum to maintain your uprightness than really what happens in true disease, which is you fall like a tree. Okay, so let me have you close your eyes and just fall back to it. Okay, and that's exactly what happens. Is they just so you got to kind of trust me. I'm a doctor type of thing for a demonstration. Please don't have anybody get a coup entry to their office.